brief learning objectives of this session. That first, we'll briefly talk about some technical issues that clinicians need to know. I will not be elaborating on that in the interest of time. We'll go through 5 simple steps to interpret ABG, because I know there are some postgraduates also here. How to recognize a mixed acid-base disorder. And then we'll go through the cases in which we will talk about how we mind the gaps, how we approach metabolic acidosis and alkalosis, and also the treatment of acid-base disorders. Okay. Having a little. Okay, so the technical issues are the pre-analytical errors, what the ABG machine measures, and checking for internal consistency. Now, the pre-analytical errors, we need to know whether it's an arterial or a venous sample, or what is, how much heparin we've used, whether pre-heparinized syringes or we have added liquid heparin, in which case we may have iatrogenic errors. Presence of air bubble, temperature, and the time taken to analyze the sample from the time of collection. Now, what the machine does when we do an ABG, it measures PO2, pH, and PCO2. It does not measure bicarbonate. Bicarbonate is calculated by the machine using the Henderson equation. When we send serum electrolytes to the biochemistry lab and they do a serum bicarbonate, it is measured. And what they measure is the TCO2, which is your dissolved bicarbonate, dissolved carbon dioxide, carbonic acid, and carbonate. So it's a total CO2 which they measure. Now, one important thing which we do not usually do, but it is important to kind of recognize whether this ABG we have is internally consistent. We have to see whether the pH which we are getting in the ABG machine corresponds to the calculated H ions in the sample. So for instance, this ABG has a pH of 7.15. So I've marked in red that the H ions that it should have is 71 H ions. And you can calculate the H ions from the Henderson equation, that is 24 into your PCO2 divided by your bicarbonate. Now, this is very important that this bicarbonate is the bicarbonate measured in the biochemistry lab. It's the measured bicarbonate. So 24 is the constant into 18 PCO2 divided by bicarb of 6 gives you 24 into 3, 72. And we got 71. So it is very close. So this is internally consistent. So this ABG is reliable. Now, there are different ways people analyze ABG. The Boston method is the one using calculations based on PCO2 and bicarbonate. The Copenhagen method is using base excess and nomograms. And the recent, which is now used by many centers, is the Stewart strong iron difference. Now, what we are going to be doing is the Boston method for calculating, which is the most common one used. Okay. Now, how do we interpret an ABG? Now, you interpret an ABG in 5 easy steps. First, we decide, look at the pH and see whether the pH is up or down. If it is pH is up, it's alkalemia. If it is down, it is acidemia. And then we see whether the PCO2 is up or down, and whether this PCO2 can explain the change in pH. Then we look at the bicarb and see whether it is deviated up or down from normal. And again, answer the question whether this bicarbonate can cause the pH change. Now, normally in simple acid-base disorders, only one can explain the pH change. It will be either the PCO2 or the bicarbonate. And so that would be the primary change, and the other would be the compensatory response by the body. So for instance, if we have this pH at 7.53, PCO2 21, bicarbonate 18. Now we know that the pH is high. You normally take 7.35 to 7.45 as your normal range. So this is alkalemia. And this pH high can be explained by a low PCO2. So you find PCO2 is low. So low PCO2 can increase pH. Now we know that the bicarb is also low, but the low bicarb cannot raise the pH. So here your primary problem is the respiratory alkalosis. So these are simple acid-base disorders where only one either PCO2 or bicarb can explain the change in pH, and the other is the compensatory mechanism. And both PCO2 and bicarb move in the same direction. Now, second example, you have a pH of 7.24. So you have an acidemia. A PCO2 is low at 28. So a low PCO2 cannot explain a low pH. The step 4 is bicarbonate. Bicarbonate is also low. And a low bicarbonate can explain a low pH. So your primary problem here is a metabolic acidosis, and the PCO2 is your compensatory response. So if you look at simple acid-base disorder, the bicarbonate and PCO2 change in the same direction. And I think we all know how to recognize metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis by following these simple methods. Now, we need to know the range of compensation. I'm just going through it because you'll be using it in the cases which we have ahead. For metabolic disorders, we use the Winter's formula for metabolic acidosis, where the PCO2 should equal the bicarbonate into 1.5 plus 8 plus or minus 2. And for metabolic alkalosis, you take 0.7 into bicarbonate plus 20 and plus or minus 5. So these are the expected compensations, because that's what we need to do, whether the compensation is within range. For respiratory, we all know we have a different compensation when it's acute and different when it's chronic. Acute respiratory acidosis, for a change of PCO2 of 10, you'll get a bicarb change of 1. Whereas if it is chronic, for the same change of 10, you can have a bicarb change up to 4. And similarly, in respiratory alkalosis, in acute, for a change of 10, you might get a PCO2 drop of 1 to 3. Whereas in chronic, it can be as much as 3 to 5 for a drop in 10. Okay. Now, when do we think of that this could be a mixed acid-base disorder? When the PCO2 and bicarbonate change in opposite directions. Okay. Second is when there's a totally normal pH in the presence of abnormal PCO2 or bicarbonate. So those values have changed, but your pH is 7.4. This is important to know because compensatory response, the so-called compensatory response that we talk about, is never restores pH to normal. It moves the pH towards normalcy. So it's only always partially correcting it. So if it looks like a fully corrected pH, there has to be a second acid-base disorder there. And third, not all it's not always that if PCO2 and bicarbonate move in the same direction, it is a simple acid-base disorder, because you can have compensatory responses which appear more than expected. Again, compensatory responses can never be more than what we have put down, because it is always restoring it partially. So if it appears that it has responded even more than needed, that means there's a second acid-base disorder which is moving it in that direction. So now we go to beyond ABG, beyond the basic ABC, and we'll go with the cases. And just to put everybody in the same page when we start, for the initial approach for analyzing an acid-base disorder, first you need to check the validity. in the cases which we are going to give, we are presuming there are no technical errors and it is internally valid. So we are not using any where there are technical errors. So we'll begin with seeing the history. You can never interpret a proper ABG without knowing something about the patient from whom you've collected it. So you already anticipate the possible derangements which the child could have based on what you're seeing clinically. As in the ABG itself, first assess the pH, identify the primary change between bicarb and PCO2, and see if the compensation is appropriate. And never forget, always see, is there an anion gap? So these 4 steps make your primary move towards analyzing your ABG. So this is the first case. This is a previously well 2-year-old child who's admitted with a complaint of vomiting for 5 days, loose motions for 1 day. Physical examination reveals tachycardia, tachypnea, and diminished skin turgor. So, Jyoti, who does this go to?
So, ma'am, I think that all the groups should go through all the questions.
Yeah.
And you can begin by ask. So once you've asked the question, everybody should sort of try and solve it. And you can begin by asking the first group.
Okay, because I cannot see the group, so you can ask which group to answer.
Yes, ma'am. And for the first breakout, ma'am, can you hear me?
Your voice went off. Now I can hear you. Yeah.
So, ma'am, for the first question and looking at the ABG, do you want to give them 2 minutes to discuss?
I want the first group, one person, to answer this question of what will they anticipate in this child? What kind of blood gas abnormality? And then I will put up the case for which we'll give them 2 minutes or whatever you decide.
Okay, so then, so they can, ma'am, anyone can answer this question.
Anyone can answer this, yeah.
So that they can answer from which room? So ma'am, we'll just let anybody answer, ma'am. At random, anybody who volunteers can answer this question, and we'll allot the rooms only once the ABG is given out.
So anybody?
Metabolic alkalosis.
Identify yourself, please, and answer. The first person who started.
Yeah, good. Metabolic alkalosis because there's been vomiting. Any other possibilities? Anybody?
If loose stool causing more bicarb loss, then it may show some acidotic changes also.
Respiratory alkalosis.
Metabolic acidosis are the most likely possibilities in the mind which we'll anticipate because the child is presented with gastroenteritis with vomiting and diarrhea. So depending on what predominated, we may get. So this is now the ABG which I'm giving. So Jyoti, whichever room has to analyze it.
So we'll break out. Now we'll break out for, I think they just need 1 minute to discuss this. And then we'll meet after 1 minute. And from the room A, first room, we'll expect one person to answer. And if they can't take, then we'll go on to the second room to answer. So all the rooms should interact, members should interact and give the answer. Okay, so a volunteer from room 1 to please answer the question on what is this ABG telling us? From the room which is Akshay Jagtap, Ankush Gupta, Arpita Dubey. Am I audible? Vidisha, Apurva Shah.
Yeah, so one person can start answering. As we said, we've already said what we are anticipating. So you can start with the PH.
Am I audible?
Yeah, we can hear you.
Yes. And here the pH is 7.15, PCO2 is 18, bicarb is 10.
Hmm.
So there is metabolic acidosis plus respiratory alkalosis, because the expected PCO2 what we want is nearly 23 plus minus 2. The PCO2 is 18. So there is some compensatory, but the compensation is not full. If we expect compensation of around 23 of PCO2, so there is not full compensation. So metabolic acidosis plus some respiratory alkalosis, because PCO2 is less.
Yeah.
And the
So,
anion gap
yeah.
is 20. So the normal anion gap is nearly 12 plus minus 4. So there is somewhat more. 20 is, can say ki high anion gap, but metabolic high anion gap, metabolic acidosis plus respiratory alkalosis.
Yeah, so I think nicely analyzed. So if you go systematically, what you will say is pH is low, so there is an acidemia. And it is a metabolic acidosis because the bicarbonate explains the fall in pH. The compensation by using the Winter's formula, I agreed it should be around 23. Over there it is 18. So a little more, which you sometimes find when the process is little chronic, that there is a little more washout than you would expect. So this is the formula we apply. So compensation is a little more maybe. So there is a respiratory alkalosis as well in this, a mild respiratory alkalosis. Anion gap, or if you take sodium plus potassium, it may be 20, but otherwise it is about 25, which is definitely a wide anion gap. So you have a wide anion gap metabolic acidosis in this child. So now my question would be, we have two types of metabolic acidosis, a wide anion gap and a normal anion gap acidosis. So what are the causes of wide anion gap metabolic acidosis?
Okay, there is some time lag, I believe, in the allotment of the rooms and the breakout room sessions. So, ma'am, we have to give them more time. We just got this feedback.
Okay.
And I also want to clarify that we want people who are in the rooms to answer. So I just need to streamline this a bit more.
Mhm.
So I want people to know that room 1, please, are you people there? Akshay Jagtap, Ankush Gupta, Arpita Dubey, Vidisha Daya, and Apurva Shah. You are in room 1. Chitra Soni, Diksha Singh, Hardik Gajar, Karishma, and Mamta Lala. You are in room 2. Krina, Madhura, Madhuri, Kadam, and Soumya. You are in room 3. Neha Bhongale, Pratik Gaune, Praveen Swami. You are in room 4. And Mona, we'll add you there now. But actually, you were not in any room and you answered out of turn, I'm afraid. Neha Shah, Vaishali, Vidya Suryavanshi, and Viraj Jain. You are in room 5. So can one person from each, so we'll put you in breakout rooms again. And I want you to at least tell me whether you are able to get into these rooms or not. Just put them in the breakout rooms. Ma'am, can you just please, I'm sorry to hold you up like this, but I just want to make sure that they are in breakout rooms. So can one person from each room tell me that you're in breakout rooms?
We have not closed the rooms yet.
No? Okay, just close them.
Close the room.
So are you in breakout rooms now? Can you interact?
No,
Huh.
they've come out of breakout room.
Okay, they've come out of breakout rooms. So, but were they in breakout rooms?
That we have to ask them now.
Okay, so were you people in the breakout rooms at all?
Yes, ma'am.
Yes, ma'am.
Okay, that sounds good.
So you guys can assign one person in each group who will be answering the question once you have been asked, so that it becomes easier when one of the group is asked to answer the question. So that will become easier.
Now they.
So can we go ahead now?
Yes, ma'am.
Yeah. So I think what we spoke was, it was a wide anion gap metabolic acidosis. And we said what we have are high anion and normal anion gap acidosis. And the question was, what are the causes of wide anion gap acidosis? Can you give me 3 or 4 common causes that you see in the ward?
Somebody from
Diabetic
number 1.
ketoacidosis.
Very good. Any other?
Lactic acidosis,
Lactic acidosis, very good.
methanol poisoning,
Ethanol,
Okay.
methanol, salicylate
Starvation.
poisoning.
Starvation ketoacidosis.
Okay. So if we broadly classify it into groups, we find that you have a group where you have wide anion gap because of renal failure, which usually happens only in advanced renal failure, not an early renal failure. You have ketoacidosis, which has many causes for it. You have lactic acidosis, and a large group which we don't see that commonly, but which we call toxicosis, a number of toxins. Okay. Now this child has BUN of 30, creatinine of 1.2, and there are urine ketones present. So what do you think is the cause of this child's wide anion gap acidosis?
So the problem is that you can't communicate.
starvation,
Starvation.
We don't know. We have a ketoacidosis in this child. And so the things you need to consider whenever you have ketoacidosis is you need to consider, could this be a DKA, which is presenting with vomiting? Could it be an inborn error of metabolism because this is a small child? Starvation. And in older adolescents, you need to consider alcohol. And at any age, you may consider toxins because the inadvertent intake of many of these may occur. So these are the important causes of ketoacidosis, which we see at the bedside. So you would need to check blood sugar. You would need to check blood ketones, lactate, if possible, pyruvate, and sometimes, because if you're thinking of IEM, then ammonia and GCMS. Now, lactic acidosis are of 2 types. We all know type A is when you have poor perfusion like shock, pulmonary edema, mesenteric occlusion. And type B where your perfusion is not affected, but the cells are unable to utilize oxygen because of cellular poisoning or bad involvement like in septic shock, hepatic disease, etc. And lastly, you have toxicosis, which you'll name many. There are many more, but some of the common ones you see are ethylene glycol, methanol, salicylates, etc. Normal anion gap acidosis, there are fewer causes. So all your GI losses, either diarrheal losses or postoperative GI losses, could give rise to non-anion gap acidosis. RTA is a very important cause, and similarly early CKD, where you will not get a wide anion gap acidosis, but because of tubular problems, you may get a non-anion gap acidosis. And very important is dilutional, if you're in ICU, because the trend for many things is to give a lot of boluses for sepsis, septic shock. And most of the time we use normal saline. And so you may have high chloride and a dilutional or a hyperchloremic metabolic acidosis. So you need to mind the anion gap whenever you're analyzing. So now I'm going to the second case. So I think room 2, Jyoti.
Ma'am, I just want to interrupt you, sorry, but your next animation slide is visible. So the answers may come up there.
Oh, okay, so I will just change the slideshow options. Okay. So this is a 4-year-old child with nephrotic syndrome who develops fever, chills, abdominal pain, and suspected to have a spontaneous bacterial peritonitis. Again, the first thing to think about is what do we anticipate in this child? What kind of blood gas abnormalities could this child have? So anyone from room 2?
Because of infection or sepsis in this case, this child can be having metabolic acidosis.
Very good.
And because of the nephrotic syndrome, and because of the respiration pattern, he can be having respiratory alkalosis also.
Yeah, so very good. So because of the pain, the abdominal distension, etc., you can have a respiratory alkalosis or a metabolic acidosis. So now this is the ABG which we have of this child, and also added other investigations which we've done in this child. So you can take a few minutes to analyze it and give your answer.
So I'll be now opening the breakout rooms. I request everyone to please interact in this breakout rooms. I'll give 2 minutes so that this time people are able to interact. That's okay, ma'am?
Yeah, it's fine.
Okay.
So shall we go further?
Ma'am, its time is not up yet.
Okay.
We'll have to wait.
I think, Jyoti, this is quite enough time because these are quite straightforward.
Right.
Hmm?
Ma'am,
so anybody ready to answer?
Ma'am, we've closed the rooms. They'll be just joining. So anybody from room number 2 ready to answer? Chitra, Diksha, Karishma, Mamta. Ma'am, please can you repeat the question?
No, I want right now the ABG analysis. because they already answered what they were expecting.
Okay, can you hear me? Am I audible?
I can hear you.
Madhura, Madhuri, Soumya.
Hello, madam.
Yeah.
So
Yeah.
pH is 7.44, which is alkaline pH.
Right.
PCO2 is less. We'll expect 30. It is little lesser than what is expected. Bicarb is also less. So it is metabolic acidosis along with respiratory alkalosis. So it looks like a mixed picture over here.
Okay. I'll just take you through the steps. Now we have a slightly alkaline pH, though we take 7.45 as your upper end of normal. Now the PCO2 is low, it's 24. So the PCO2 can explain this pH going higher. So you primarily now have a respiratory alkalosis. Okay. Now a low bicarb cannot explain this pH. So the low bicarb will have to be the compensatory response for the PCO2. So expected compensation is if there's a fall in PCO2 by 16, you might expect a fall in bicarb anywhere between 1 to 4, depending on. For 10, you expect between 1 to 4 fall. So about a 6 fall may be expected at the maximum. It's fallen maybe a little bit more. So there is some element also of metabolic acidosis. And what about the anion gap? I give you that also. So when you calculate, your anion gap looks as 12. So what would be your conclusion here? Hello?
Respiratory alkalosis with compensated metabolic acidosis with normal anion gap.
Okay. So is there anything else when you see a anion gap? Is there something you need to correct it for?
We need to calculate corrected anion gap with albumin, as albumin is low, 1. So
Right.
corrected anion gap is 19.5. So it is high anion gap metabolic acidosis.
Yeah. So very good. So it's important that, you need to remember that whenever you have you should ask for an albumin value when you expect it to be low. And you have to correct for albumin. So there the albumin looked normal. But when you see the albumin correction, now how do you do albumin correction? Whatever is your albumin, you take normal as 4. This child had 1 albumin. For 4 minus 1 into 2.5. So it'll be 7.5. So when you add the 7.5 to the 12, you get 19.5. So this is actually a wide anion gap acidosis, which we would have mistakenly called normal anion gap acidosis if we did not do the albumin correction. And the reason why we're looking at it is if you see that when you say your anion gap, normally you're not, the gap is coming from the unmeasured anions. And one of the main unmeasured anions, almost contributing 80% to that unmeasured group, is your serum albumin. Okay? So when your albumin levels fall, this anion gap will narrow. So it may hide, if there are true other organic anions, it may spuriously appear normal because to begin with it was low. So instead of the normal 12, it was only 8 because your albumin was low. And now there is some anions added to it and it becomes 12. So it looks as if it's normal, but that was because to begin with it was low because of serum albumin. So never forget to correct for albumin. So your first lesson was always look for anion gap. Second is correct the anion gap for albumin so that you get the true anion gap. So now when you see the diagnosis, you have a respiratory alkalosis, which you can eyeball and say. When looking at it carefully, you found a metabolic acidosis, and when you collect corrected for albumin, you found that this was a wide anion gap. So this is a mixed acid-base disorder. It is not a simple acid-base disorder because a metabolic acidosis is not there for compensation. It is there because the anion gap is itself wide. So the effect of this on your management is that when you have this wide anion gap, you know that this child is more sick than what we clinically assessed, because this may be coming from part of sepsis, and that is why the anion gap is wider. So you would be more careful and aggressive in the management of this child. So hypoalbuminemia is common in critical illness. So it is not just a nephrotic syndrome. It's there in many ICU patients. So low serum albumin will narrow your anion gap. So it may mask the presence of other anions, which normally go unmeasured. So you have to apply the correction factor. So 2.5 into the difference in albumin, usually 4 minus the serum albumin you take into 2.5, you need to add to your actual anion gap. So we come to the next case. This is a 1-year-old child who's investigated for failure to thrive and poor feeding. So do you anticipate any metabolic disorder in this child?
Yes, ma'am. 1-year-old child with failure to thrive and poor feeding can have like metabolic acidosis because of the starvation, or if there is vomiting, persistent vomiting, then it can have metabolic alkalosis.
Yeah. So we've not been given more history, so we don't know. But yes, their child could have some metabolic problem, either as a cause or effect of the failure to thrive. Now, this is the ABG we got. We got a pH of 7.5. You can go ahead and sort out the ABG, and then whoever's ready can
So
give
I
the
request all of
answer.
them to write this on the piece of paper, because once you go into breakout room, you're not able to see the main screen, so that it will become easier for you to discuss then. Now I am putting you all in the breakout rooms. Ma'am, should I close the breakout rooms?
Yeah, you can. I think because by now they are quite good at it.
So I request one of the participant from room number 4 to answer. So that is either Dr. Mona, Neha, Prateek, or Praveen Swami. Either any one of them. Neha, you want to volunteer?
Ma'am, pH is 7.5. That is on the higher side. It is an alkalosis. PCO2
You
and
call it, see, when you're talking of pH, call it alkalemia. alkalosis is the process.
Okay,
The
sorry.
change you see in the blood is alkalemia.
PCO2 and bicarb is also on the higher side, so it should be an metabolic alkalosis. Electrolytes are showing sodium 135, potassium 2. So hypochloremic, hypokalemic, hyponatremic metabolic alkalosis. The compensation is almost
Adequate
compensated metabolic alkalosis.
Okay, so let us see how it is. You're right, you have an alkalemia over here. The PCO2 is high, it cannot explain the alkalemia. Your bicarb is high, it can explain the alkalemia. So expected PCO2 for this level of bicarb will be about 47. So the compensation is fairly good. So this child has a metabolic alkalosis. Okay. Now, when you have a metabolic alkalosis, and what you have is you have a mild anion gap increase. Remember, it's always important to calculate anion gap no matter what you're getting. And you've got a small anion gap of 17, which we'll come to little later. When you have a child, now you have a child with failure to thrive and metabolic alkalosis. So what are the possibilities that come to your mind? Because it's quite a severe metabolic alkalosis. It's not a borderline one.
Ma'am, if patient is having vomiting or upper GI symptom, it may be CHPS. Or patient is having any polyuria, then or channelopathy, it may suggest of channelopathies.
Yeah, I think very important one, don't use short forms when you're presenting, because those are known only to you. So upper GI losses, so vomiting. So it obviously it has to be a persistent severe vomiting, which may have been there, causing the alkalosis. Or you may have, if you have history of polyuria, which you rightly pointed out, you may be dealing with a tubular disorder, which is causing some chloride losses, and you might get alkalosis. So what is the single test you can do to decide whether this bicarbonate high has come from extrarenal losses or renal losses?
Urinary chloride level.
Excellent. So the single most important test is a urinary chloride level, which you should do before you start correcting and treating the child to get your knife sample. And what would you expect if it's extrarenal losses? Supposing it's due to vomiting per se.
Less than 15 milli.
It's usually, so you're basically trying to see if it's extrarenal losses, your urine chloride will be less than 10. So it's really low urine chloride because they've absorbed everything. And common causes are vomiting, but you also need to remember sometimes you would get skin losses like in cystic fibrosis. You don't get it in normal skin losses, but cystic fibrosis children have high chloride losses through the skin. So they may get a metabolic alkalosis without vomiting and without polyuria. Prior use of diuretics, if for somebody is given diuretics for some reason and now it's stopped, it may still leave behind metabolic alkalosis and a low urine chloride. And in ICU, post hypercapnia, that means your child has had a high PCO2, and so the body has generated a high bicarb. But by ventilation, you can rapidly bring down the PCO2, but your bicarb cannot come down fast. So you suddenly get a metabolic alkalosis. And if you see the urine chloride, it will be low. And that gets corrected if you give adequate chloride. So these are all chloride responsive metabolic alkalosis when you have extrarenal losses. As opposed to that, when you have a renal cause, you will always get a history of polyuria, and your urine chloride will be more than 10 milliequivalents per liter. And the most common one which you see is Bartter syndrome. I mean, rare compared to vomiting, etc. But amongst the renal, Bartter syndrome and the other situations where you have aldosterone excess, like Cushing's or pure hyperaldosteronism. And sometimes due to just profound potassium depletion, you can get a secondary metabolic alkalosis. So that is the importance of doing a urine chloride to differentiate what kind of metabolic alkalosis you're dealing with. So I think this must be case 4, it's mislabeled. A 5-year-old child is admitted with fever, cough, breathlessness, right upper zone pneumonia. Heart rate is 160, respiratory rate 44, and CRT is 3 seconds. So what are we anticipating in this child? Like, what are all possible blood gas derangements that could be present?
Respiratory acidosis.
Very good.
Alkal.
Yeah, or respiratory alkalosis, depending. We don't know. Yeah.
Impending shock.
So if it's impending shock, does it cause any metabolic derangement?
Metabolic acidosis.
Yeah, so you could be having metabolic acidosis. So we have a lot of possibilities in this child, and let us see what this child has now. So this is the basic ABG report which I have. So you can think over it and let me know what.
Ma'am, I'll put them in the rooms.
Yeah, yeah. So shall we go ahead with the answer? Because we've got just a brief ABG here.
Yes, ma'am.
Yeah. Yes. So who's answering?
So someone from room number 5, Vaishali, Vidya, or Viraj, one of you can answer.
Yes, ma'am. So, ma'am, this is respiratory alkalosis, and if we see the type of compensation for this pH, so it is compensated bicarb, so compensated respiratory alkalosis.
Okay. So very good. So what we have here, let's see. So we have an alkalemia. We have a PCO2, which is low, which can explain the alkalemia, and a bicarbonate, which is moving in the same direction, which cannot. So we have a respiratory alkalosis, and the compensation is within expected range. Okay. Now, is the diagnosis complete from the same breakout room? Would you want any more information from me?
Lack.
I'm getting a little breaking of the voice, so if you can just clearly speak.
PaO2.
We are not going to be discussing oxygenation in this session because that will take a full session by itself. So we are looking right now not at the oxygenation part.
Electrolytes.
Electrolytes.
Why do you want electrolytes? You have to give me a reason for me to provide it.
Chloride loss.
Why are you thinking of chloride loss? You're talking of respiratory alkalosis, no? You're not talking of metabolic alkalosis. Your answer of
Want to know the
electrolytes is correct.
actual anion gap to see.
Yeah, very good. See,
We
no
have to
blood
see
gas
anion gap.
no blood gas interpretation is complete without looking at the anion gap. Okay. So always when you give a blood gas analysis, always see that you've been given the anion, the electrolytes, so that you can calculate an anion gap. So now I've given you the electrolytes. So what is your anion gap?
Anion gap is 25.
25, very good. Okay. So now what does your diagnosis change? Your initial diagnosis was a respiratory alkalosis. Now you have a wide anion gap. So what does your diagnosis now become? Your bicarb is 21. It is not low. It is not in the acidotic range. Anyone from room 2, the current room, wants to answer? Otherwise, anyone else can answer from the other rooms.
High anion gap metabolic acidosis with respiratory.
Very good. So irrespective of what your pH looks like, irrespective of what your bicarb looks like, if you have a wide anion gap, you have a wide anion gap metabolic acidosis. So that this is the basic principle. So you have a respiratory alkalosis, which was correct, but you also have a wide anion gap metabolic acidosis, which you would have missed totally if you had not asked for the electrolytes. So what your initial guess was that this child could have a respiratory alkalosis or acidosis, you've been proved right, got respiratory alkalosis. You also suspected that this child may be going into septic shock, so could have a metabolic acidosis, which also you've been proved right that this is a wide anion gap metabolic acidosis. Is there something more we need to check now?
Delta anion.
Delta anion gap.
Very good. So how do you calculate delta anion gap?
Anion gap minus 12.
Yeah. So anion gap minus 12 give you your delta anion gap. And what use will you make out of this delta anion gap?
We have to compare delta anion gap and delta bicarb. We have to see their relationship.
Okay. And so what will you conclude with that?
Bicarb deficit.
Ma'am, that will give us the whether if they are equal, so that will be pure high anion gap metabolic acidosis. If delta anion gap will be more than delta bicarb, then we will be having high anion gap metabolic acidosis with metabolic alkalosis.
Yeah. So excellent. So you have to always see when you have a wide anion gap, you also have to see is there a bicarbonate gap. So what you're trying to say is the change in anion gap equal to the change in bicarbonate. So the change in anion gap in this child, we have an anion gap of 25. Normal anion gap would be only 12. So you have a delta anion gap of 13. Now, if there's a 1-in-1 equation, then your bicarbonate also should fall by 13 and you should have had a bicarbonate of 11. But you're actually having a bicarbonate of 21. which is, 10 more than expected. So you have a higher hidden bicarb than what it is appearing. So there was an underlying metabolic alkalosis over and above this has happened. So what you're really having is a triple acid base disorder, where a respiratory alkalosis you got by merely eyeballing it, wide anion gap acidosis you got by calculating anion gap, and the metabolic alkalosis you have to search for it by looking for the delta anion gap and the delta bicarbonate gap and seeing the relationship. So you have this delta ratios, but it is also simpler to just see what is happening because it helps you to understand what has happened behind by seeing whether the change in anion gap is accounted for fully by the change in bicarbonate gap or it is different. So probably this may mean that this child could have had vomiting initially before he started with the respiratory and then the respiratory alkalosis and then the sepsis and the wide anion gap acidosis. So that was well done. We go to the next case. This is a 2-year-old girl weighing 7 kg, brought with a history of lethargy, fever. Her sensorium is poor and her breathing is fast. So anybody wants to kind of think about what are the possible blood gas derangements we could get?
Metabolic acidosis with respiratory alkalosis.
As breathing is fast, so respiratory alkalosis we can get.
Yes. So you're saying metabolic acidosis because of?
Dehydration can be there due to fever.
Okay.
Sepsis.
So there could be metabolic acidosis. She's breathing fast, so there could be respiratory alkalosis as well. So this is the blood gas. Yeah. So I think Jyoti, you can give them into their breakout rooms.
Yes. Just everybody should note the numbers, please, and then we'll put you into the rooms quickly. Ma'am, time is up. 2 minutes are up.
Yeah. So can we have somebody volunteering to answer from the room?
Ma'am, we'll shift again to room number 1. So anyone Among Ankush, Arpita, Vidisha, or Apurva, one of you can please volunteer to answer.
Ma'am, as the pH is 7, so there is acidemia. And
Just one second.
as the
One sec,
PCO.
Chitra, just a minute. Can you just please hold on, Chitra? Ankush, Arpita, Vidisha, Apurva, are you there?
Yeah.
Please answer.
pH is 7, so there is acidemia, and PCO2 is 30, which go with acidemia. Bicarb is 5, which goes with acidemia. So it is metabolic acidosis, and the compensation is inadequate. Compensation should have been 18, but PCO2 is 30, and the anion gap coming is 24. So it is metabolic acidosis with compensatory respiratory alkalosis with high anion gap.
Almost there. Okay, so you were very good. Acidemia, low PCO2 cannot account for the low pH. Low bicarb can, so it's a metabolic acidosis. Expected compensation is about 18, but the actual PCO2 is 30. So there is inadequate respiratory compensation. So this is actually a respiratory acidosis. Because once you fail to compensate and you're so much higher, that means your PCO2 is not getting blown off as it should. So there's a respiratory acidosis. And as you rightly mentioned, there's a wide anion gap acidosis. So we have multiple issues here. Your wide anion gap acidosis, which seems quite severe. And there is a respiratory acidosis, which means there's poor compensation that is happening. Would you like to take this a step further?
We'll have to calculate
Yeah.
delta anion gap.
Yeah. So what would be the delta anion gap in this?
12, ma'am.
12. And so with the expected bicarb, what would you say now? What is the bicarbonate gap coming to?
Actually, it's 5 and
more than delta.
No, can you repeat what you're saying about the bicarb?
Actual bicarb is 5.
Yeah.
And delta anion gap here we are getting 12.
Yeah. So you should have had a bicarb of how much? If you have a 1-in-1 change, your bicarb should have been how much? So for a change of anion gap of 1, if your bicarb should fall by 1, then you should have a drop of bicarb by 12, right?
Yes.
Yeah. So if you see your delta anion gap, you have an anion gap of 25 or whatever, minus 12 is 13. You would have expected a bicarbonate of around 11, but your actual bicarbonate is 5. So if you see your bicarb has fallen much more than you would expect by the wide anion gap. So instead of stopping at 11, it has gone down further even to 5. So you got now a bicarbonate gap, which is negative. 5 minus 11, that's 6. So that means there was already a non-anion gap acidosis. So this is the reverse of that hidden metabolic alkalosis, which you found in the previous case, where the expected bicarb was actually, the actual bicarb was actually higher than the expected. So you had a metabolic alkalosis. Here, the actual bicarb is actually lower than the expected bicarb. So there is a pre-existing process which has lowered the bicarb. So there is a non-anion gap acidosis in this child as well. So now if you see, this is again a triple acid-base disorder. There's already a wide anion gap acidosis. There's a normal anion gap acidosis, which you found by calculating your delta gap. And you have a respiratory acidosis because the kid is not compensating. You know? So probably if you put all this together, you might probably conclude that this child had a previous normal anion gap acidosis, so may have been an RTA or an early CKD, which creatinine may tell you, over and which the child developed some sepsis, he had fever, lethargy, so developed a wide anion gap acidosis. And because the child is malnourished, not thriving, he cannot compensate for this and is going into respiratory failure and is developing respiratory acidosis. So the entire picture of what this child could have had to begin with comes when you calculate everything together. Okay. So we go to the 6th case. Okay. So here the ABG is visible. Okay. But just to go through, this is a 16-year-old male discovered unconscious in the park, brought to the emergency department. Physical examination shows a BP of 120/50, heart rate of 120. So there's tachycardia, there's tachypnea, there's a wide pulse pressure, which you're seeing, and he is unconscious. Okay. And this is the ABG we have. So I think they can go into the breakout rooms and sort it out, and then we can come out for discussion.
Yes, ma'am. We just let them note the numbers if they want.
Yeah.
They are back. So who are the people who?
Yeah. So who's supposed to answer which group?
The most enthusiastic. So Chitra, Diksha, and Mamta.
Okay.
So Chitra, Mamta, and Diksha, you can answer now. Interpret the blood gas. Mamta, can you hear me? Are you there? Mamta, Chitra? Okay, anybody from Madhura, Madhuri, Soumya?
So, hello, ma'am.
Yeah.
So pH is 7.53, which is a respiratory, which is alkalemia. PCO2 is 25, so which is less. That is again going with the alkalemia. Bicarb is 21, which is also less, or more or no less normal. So this looks like to be respiratory alkalemia. The anion gap comes to 40. It's a wide anion gap, so we'll have to again calculate delta anion gap.
Very good. So just to go up to this point, you have alkalemia, low PCO2, so straightforward respiratory alkalosis, appropriate fall of bicarb, and a wide anion gap acidosis. So this is really a very wide anion gap. It's 40, which you don't usually encounter. Yeah, go ahead.
So
So
the
what, yeah.
expected bicarb is 24 and we have got 21.
Yeah.
So
Bicarb is 7.
Yeah, so this is what happens when you have some very wide levels. You find that, you can't really apply your calculations that well. But you can see your delta anion gap is almost 28. So actually your expected bicarb will be very low. I mean, can't go below 0. So you expect like 1, 2, 3 kind of bicarb. Whereas your actual bicarb is 21. So there is definitely a metabolic alkalosis over here, which you have detected. So you have again a triple acid base disorder, respiratory alkalosis, wide anion gap acidosis, and metabolic alkalosis. So now, is there something more? We have now this kid who's unconscious. His vitals look very bad. And besides the blood gas, he's got mild hyponatremia, hypokalemia. Everything looks very deranged. Now, is there something more we can do to arrive at what
urinary
is happening?
chlorides?
How would it help in what way?
There's a hypochloremia and hypokalemia both.
One thing is that when you have a mixed acid base disorder, these urinary values may become much more difficult to interpret as opposed to that simple metabolic alkalosis which we had earlier, which did not have any other acid-base disturbance. Straightforward metabolic alkalosis, your urine chloride helps. But when you have a mixed picture like this, they're all interacting with each other. And so based on one urinary parameter, you may not be able to conclude.
Sugar?
Yeah, sugar is very important. What else? Because we are now primarily looking at what is causing the wide anion gap acidosis. So you want to rule out a decay. So sugar, what else you look out for?
Ketones?
Sugar and ketones, then? Maybe lactates?
Yes.
Yeah, because he had that pulse pressure also, which was wide. And maybe a BUN creatinine, because that's again one of your causes for a wide anion gap acidosis. Okay, so if you look at, we have a BUN of 28, a creatinine of 1.4, a glucose 180, ketones weakly positive, your albumin is normal, so you don't have to do an albumin correction. So based on this, can you kind of think what he could be having for this wide anion gap acidosis? Do you think the renal function explains it?
So, ma'am, the creatinine is little bit on the higher side.
So do you think the renal failure could cause this wide anion gap?
Yes, ma'am.
So the answer would be no, because you have a 16-year-old boy. Yes, his creatinine is high, But 1.4 is not very high for a 16-year-old boy.
Okay.
So it's got a mild impairment, of the kidney. And in the mild renal impairment, you usually do not get a wide anion gap acidosis. So the wide anion gap is not fitting in with that BUN creatinine, though some contribution could be there. Do you think this child has a DKA? He has a glucose 180, ketones weakly positive.
Less chances. Bicarb is,
Yeah.
the acidosis is not pH 7.5, bicarb is 21.
No, you're missing the point. That's why we went back to that thing that no matter what it looks like, you have an anion, your acidosis is masked, the severity, because there are two alkalotic components. There's a metabolic alkalosis and a respiratory alkalosis, which are making your ABG report look very innocuous. But when you yourself analyze, you find it's not such a straightforward, simple respiratory alkalosis. There's a huge anion gap acidosis. So once you have that, no matter what your pH and bicarb look like, this is a severe, very severe acidosis.
So what was the lactate?
I do not have a lactate value, but that is an important question. We need to know how much was the lactate which this child had. So your typical DKA has a glucose more than 200 and ketones that are strongly positive, though you may sometimes get a weakly positive ketones because the test you do for ketones, nitroprusside test, detects acetoacetic acid and acetone and does not detect beta hydroxybutyric acid, which would be the main keto acid which would be excreted in the decompensated state or in the acute DKA state. So, but the glucose is only 180, which just seems unlikely unless he was a known previous diabetic who was taking insulin. You will not get a DKA with such low glucose thing. So the third, and assuming your lactate is somewhat high, very rarely you get in septic shock anion gap of 40. It's quite uncommon. So when you have such a wide anion gap, you're pretty sure there's some organic acids accumulating. Okay. So we go back to the same topic. We don't have probably not really a DKA. Starvation in such a big child. He didn't look like a starved kid. He was a 16-year-old, otherwise healthy boy. IEM, it's too late for an IEM to begin. So although there are ketones, none of these seem to be clearly fitting in. So you need to clearly think about toxins in such a case. And one of the tests one of the bedside kind of things which may help you, though it's neither here nor there in concluding it, is an osmolar gap. Okay. So as I said, neither DKA, not convincing, no IAM starvation. The toxicosis is important because this was a 16-year-old boy brought unconscious. So you need to think of toxins thing. So you look at what is an osmolar gap. Now this you do by measuring osmolarity and calculating the osmolarity. The measured osmolarity, which you may do by the freezing point depression or the vapor pressure method, was 302. You can calculate the osmolarity. All of you all know 2 times your sodium plus your glucose upon 18 plus your BUN upon 2.8. So your calculated osmolarity comes to 282. So you have an osmolar gap of 20. Your normal osmolar gap should be less than 10. So you also need to look at what are the causes of increased osmolar gap. And you might get a number of toxins in that. So these are all your low molecular weight solutes which are not charged, but which accumulate to increase your osmolarity. So from ethyl alcohol, methyl alcohol, ethylene glycol, propylene glycol, acetone, mannitol can all give you an osmolar gap. You can also increase osmolar gap with DKA and lactic acidosis, so they are not totally excluded from the picture. But considering the overall picture and the extremely wide anion gap acidosis, one would look towards toxicosis. So you may need to do blood levels of ethanol. You may need to do a toxicology screen for a whole lot of things besides what I've put here to arrive at a diagnosis. Okay? Now, we used to use, I don't like mnemonics, but this one is a useful one. We used to use quite commonly mud piles, which has now become very irrelevant because many of the things there are not things which we are really using and which cause wide anion gap acidosis. So the new mnemonic put forward is gold mark. G is for all your glycols, your ethylene glycol, propylene glycol, etc., which are not uncommon toxins because they're found in common things like your antifreeze and your wiper fluid and various other things. Oxoprolin, which is a metabolic product from drugs like paracetamol, oxacillin, etc., fluoxacillin. So an important thing to keep in mind. So the history is important, what all he's been taking. Lactic acid, L-lactic acid, D-lactic acid, which comes from the gut bacteria, methanol and other alcohols, ethyl alcohol, isopropyl alcohol, A for aspirin, R for renal failure, and ketoacidosis, which we already mentioned. And in ketoacidosis, you need to add alcohol. So there is a strong suspicion that this could be an alcoholic ketoacidosis, which this child is having. He could have been vomiting before, that's why I found the metabolic alkalosis. And now, because of all this osmolar accumulation, he's got altered sensorium, etc. But always remember that many times it may not be pure ethyl alcohol. There may be other more dangerous alcohols mixed. So you need to do an ethanol level. And if that doesn't account for the osmolality, then you need to look for the other toxic screens. So there's a double gap, there's a wide anion gap, plus an osmolar gap. So these are all the gaps we need to mind. So we come to the last case. This is a 3-year-old child admitted with vomiting, altered sensorium. She had been a preterm baby who had suffered from NEC, undergone bowel resection. Her current weight is 10 kg. She had a similar episode six months ago, and this is her ABG.
We'll make the rooms now.
Yeah. So should we move on to the answers?
Ma'am, I'll just close the breakout room.
Yeah.
So someone from room 4 can answer either Neha, Pratik, Praveen, or Dr. Mona.
Yes. Yes, there is pH is 7.15. So there is acidemia. Bicarb is 7. PCO2 is 16. So they are going to acidemia. So there is metabolic acidosis. And the compensation is fully, though there is compensatory metabolic acidosis, we are expecting compensation of CO2 of 18.5 plus minus 2. So there is full compensation, compensatory metabolic acidosis. Here the anion gap is 20. So more of wide anion gap metabolic acidosis.
Okay, so very good. So you have acidemia, metabolic acidosis, compensation appropriate, and an anion gap. I don't know if I put different values in different places. Anyway, a wide anion gap metabolic acidosis.
Sorry, ma'am. Yes, yes, 30. Sorry, ma'am.
Yeah, so it's a large anion gap. Yeah.
Yes. And the
I think
delta
the
gap.
importance of a large anion gap acidosis is very important compared to a 20, which is also important. We'll come to that later. So what do you want to know next? Hello? Hello? Can you hear me?
Audible to us, but I don't know what's happened to the person who was talking.
Yeah, I mean, after this wide anion gap, is there anything more you want to do or ask or whatever? I think your voice is not coming clearly, so maybe then somebody else can answer.
So either Neha, Pratik from room number.
Albumin level, ma'am.
Albumin level is normal.
Lactate levels.
Lactate is, I'll show you those reports. 1 second. So you have to first finish your delta anion gap, because whenever you have a wide anion gap, you have to look for delta anion gap, which is 18. So the expected bicarb would be 6 and actual bicarb is 7. So really there's no hidden other metabolic disturbance. It's a plain, simple, wide anion gap metabolic acidosis. And these are all the reports I have. I have a BUN of 10, creatinine of 0.7. Urine ketones are negative. The lactate is 0.7 millimoles per liter, which is normal. And we also checked ammonia because of altered sensorium, which was normal. So now, what would be the cause of this wide anion gap acidosis? So it's not a ketoacidosis, it's not a lactic acidosis, it's not a renal failure. So one thing again, even though the child is small, we need to keep toxicosis in mind. But is there anything else that could be?
The child was operated for something?
Yeah, you have operated for NEC in the newborn period. Child had a resection and anastomosis.
So the small gut size.
What does it lead to?
Loss of
Yeah, I think you're very close. The short gut is the cause. Yeah. So that's what makes your history very important. This child has a short gut and the child has had one previous episode like this before. So what do you have is here what we call D-lactic acidosis. Now the normal lactate we have in our blood is L-lactate, which is the levo form which is produced in the body during your anaerobic metabolism and your glycolysis, etc. D-lactic lactate is not produced by humans, but it is produced by bacterial overgrowth in the short gut. So whenever you have a short gut, you have a bacterial overgrowth there. And this production of D-lactate will increase whenever the carbohydrate intake is high. And this D-lactate cannot be metabolized by humans. So it has to get excreted in the urine. So till it is not fully excreted, it will cause a wide anion gap acidosis, and it can also cause altered sensorium. And the usual lactate test which we do does not measure D-lactate. So a normal lactate means normal levolactate, but not the delta variety. And it can cause vomiting and altered sensorium. And so you may typically see it that the child has attended some function or some birthday or some festival, has had a lot of sweets, cakes, ice creams, etc. And next morning, the child is altered sensorium, breathing rapidly, and comes to the hospital. So these are some things which need to be kept in mind in the specific group of children who have short gut syndrome.
So, ma'am,
Yeah.
So this D-lactic acidosis is diagnosis by exclusion.
Yeah, because as of now, we don't have a lab which will measure D-lactate. Okay. So it's basically a diagnosis based on the background where you can generate D-lactate. So that's why the history is important, that NEC, that short gut, gives you the possibility, because when you have everything negative, you also have the possibility of toxins. So it is not that D-lactate would only be the default diagnosis. It could be a number of other toxins which we spoke about in that gold mark. So you would have to consider both based on the history you get and the background you have. The only thing is probably the child, many of these recover undiagnosed because unconscious, altered sensorium, child is NBM, child is on IV fluids. And within 48 hours, if your renal function is good, with the IV fluids and stopping the oral carbohydrate, the D-lactate production stops and it's excreted by the kidney quite well in the absence of any AKI. And so the child recovers. So sometimes these children recover and the diagnosis is not known or is wrongly attributed to something else. So they could have such repeated episodes as well. So I'll come to the end to conclude. For the treatment of acid-base disorders, you need to treat the primary disorders. For the non-anion gap metabolic acidosis, very often you may give bicarbonate, which will correct the acidosis. These may be renal or your GI conditions. Most diarrheal dehydrations, you may not need to specifically address the bicarb, but your correction of dehydration itself may correct the acidosis. But in other cases, you may need. However, if you have a high anion gap metabolic acidosis, giving bicarb is not the answer. It could even be detrimental. So you don't treat the acid-base disturbance directly unless the changes are so severe that it's likely to affect cell or organ function. So if your pH is less than 7.1 or your bicarb is less than 5, then you would need to treat to some extent ameliorate your pH, even though it's a high anion gap metabolic acidosis. So to conclude, summarize all that we did today, the points to remember: check internal consistency and validity of the ABG. When you do that, you have to use the serum bicarbonate and not the bicarbonate of your ABG. You use the PCO2 from the ABG and the bicarb from the serum. Analyze ABG in 5 simple steps. Simple acid-base disorders have PCO2 bicarb which move in the same direction, and only one parameter can explain the change in pH. All acid-base disorders where PCO2 and bicarb move in the same direction are not simple disorders. Check the range of compensation. If it's excessive, there's a second disorder. PCO2 and bicarb move in opposite directions in mixed acid-base disorders. A totally normal pH in the presence of PCO2 and bicarbonate changes suggests a mixed acid-base disturbance. Acid-base disturbance can exist even with totally normal pH, totally normal PCO2 and totally normal bicarbonate. That's why before you say no acid-base disturbance, check your anion gap. So always check anion gap, look for the delta anion gap and the bicarbonate gap, look for gaps in the anion gap and correct for hypoalbuminemia. So you have to mind 5 gaps: the anion gap, the albumin gap, the bicarbonate gap, the osmolar gap in selected cases, and finally the biggest gap is the gap in our minds where we don't think of things which we can do. So I'll end with this. If there are any questions, we can take them.
Ma'am, metabolic alkalosis, why it is like chloride responsive? Why we say it as a chloride responsive and non-responsive?
Because when you have an extrarenal cause, it has primarily come from the extrarenal chloride loss. So when you replace it, you also correct the alkalosis because the kidney will start excreting the bicarb once it gets the chloride to maintain electroneutrality. Whereas when you say non-responsive to chloride, it's because the primary cause is a mineralocorticoid excess. So unless you treat that, you will find just giving chlorides may not solve your problem. It could improve the thing to some extent. It's not that it will not improve at all, but it will not solve your problem. It will keep happening. It'll be incompletely corrected, like for Bartter syndrome. Unless you specifically treat for the prostaglandin excess, etc., it's not going to get better.
Oh,
Ma'am,
thank you, ma'am.
How to calculate albumin gap? My connection had got disconnected in between.
So if your measured albumin is 1, patient has an albumin of 1, you normally would expect 4 grams as your normal albumin. So it is dropped by 3. So that drop multiplied by 2.5. So 3 into 2.5 will be 7.5. And that if you add to your whatever anion gap you got by straightforward calculation, it will give you the true anion gap. So 2.5 into the change in albumin.
Okay. Okay. Thank you, ma'am.
So any more questions we can take? Otherwise, we can end the session.
Role of base excess of ABG reports.
See, I have not gone into it. As I mentioned, there are different ways in which you can approach your interpretation of blood gases. So in the Boston method, which we've used using bicarbonate PCO2, we don't look at base excess. Okay. In the Copenhagen method, we use base excess and the nomogram to get your answer. So every method has some strengths and some weaknesses. Like a base excess, for instance, tells you upfront you have a metabolic problem, but it does not tell you what caused it. How have you arrived at it? Whereas by the Boston method, by going sequentially, you kind of get almost a pictorial idea of what could have happened to this child sequentially, that the child is currently in this stage. But it has its drawbacks, and so there are proponents for one or the other. So you can use whichever method you've been trained in and which you find comfortable. At the end result will be similar.
Ma'am, in respiratory acidosis or alkalosis, we have always in alkalosis, we always have to see whether the condition is acute or chronic.
By history, you might get an idea of how long it has lasted, because acute would be like, a few hours or a day. Anything more than that, chronic in the sense that the kidney starts adapting. Kidney cannot adapt to the PCO2 within few hours. So it might take longer than that, start adapting after 12 hours something, and then the adaptation may be complete by 48 hours. That's why the compensation would be very little in the acute phase, but will increase after 48 hours.
Okay, ma'am.
Yeah.
So, ma'am, many people have left nice messages for you in the chat box. So, Ranjit Thirgaonkar has said, excellent session. Thank you, ma'am. And there's Dr. Mona has thanked you, and the discussion was nice. And Nivedita Pandey has simplified to the best, and many dilemmas have been resolved. And so everybody's saying it's been wonderful, and thank you, ma'am.
Thanks, Jyoti, and thanks, everyone.
And thank you very much, ma'am. So I think, and ma'am,
Thank you, ma'am.
session. So once you've gone through it again in the recorded session, and if you will give us permission, then people can also listen to it again at the Kidney Foundation site later.
Yeah, we can. Only thing is, this would be a little longish because we've had the question answer. If you think that's fine, then it's okay. It's fine with me.
That would be fine, ma'am. That will just add to the interest. So once you've gone through the recording later, we'll put it.
Okay, sure. Yeah.
Thank you very much, ma'am.
Okay.
It's been a great session.
Bye.
Thank you.